start the program. She has shared the link, YouTube link. So the participants here, you can please share this link with everybody, with all your friends and acquaintances, so that whoever is unable to join the G Meet, they can now see it in YouTube streaming. All right, so good morning, good afternoon, everybody present here. Very warm welcome to all our participants, speaker, and organizers of this event. As we observe the sixth Rastriya Poshan Maah 2023, the theme for which is Poshit Bharat, Sakshar Bharat, Sashakt Bharat, that is Nutrition Rich India, Educated India, and Empowered India, through a series of events, one of which is today's webinar on carbohydrate counting and diabetes mellitus. I request the IQAC coordinator of our college, GOKHALE Memorial Girls College, Dr. Shonjita Sen, to kindly deliver her welcome address. Shonjita ma'am.
Thank you, Pratasha. Can you see me on the screen? Because I can't see myself.
Yes, ma'am, you are visible.
Thank you. Thank you. Good afternoon to all present here. I welcome you all to this webinar today on carbohydrate counting in diabetes mellitus, being jointly hosted by GOKHALE Memorial Girls College and PANIHATI MAHAVIDYALAYA. Nutrition actually is a critical part of health and development. Better nutrition is related to improved infant, child, and maternal health, stronger immune systems, safer pregnancy and childbirth, lower risk of non-communicable diseases such as diabetes and cardiovascular disease, and longevity. There is a strong link between nutritional status, educational status, and economic status of a country. Healthy children learn better and are more productive. In India, the National Nutrition Week is observed every year from September 1 to September 7 to raise public awareness about nutrition and health eating habits. National Nutrition Month is an annual nutrition education and information campaign created by the Academy of Nutrition and Dietetics that is celebrated each year during the month of March, focusing on the importance of making informed food choices and developing sound eating and physical activity habits. Every year, the Poshan Maah is celebrated under Poshan Abhiyan, the Prime Minister's overarching scheme for holistic nourishment, launched in 2018. Poshan Abhiyan has set goals. Poshan Abhiyan has set goals to reduce child undernutrition, low birth weight, and anemia across age groups and create a mass movement for good nutrition in the country. This year, we are observing the sixth Rastriya Poshan Maah during the month of September through the Department of Clinical Nutrition and Dietetics, GOKHALE Memorial Girls College, in collaboration with the Department of Food and Nutrition, PANIHATI Mahavidyalaya. This year's theme focuses on activities based on exclusive breastfeeding and complementary feeding, Swasth Balak Spardha, and Poshan Bhi, Padhai Bhi, improving in nutrition through mission, life, Meri Mati Mera Desh, tribal focused nutrition sensitization test, treat talk anemia, and such others. It's my pleasure to introduce today's speaker, Srimati Komal Srivastav, a senior dietitian, Apollo Multi-Speciality Hospital, Salt Lake, Kolkata. Komal Srivastav has a B.Ed in Home Science from Jadavpur University. She passed her MSc in Food and Nutrition in the year 2007 from Bhartihar University, RVS College of Arts and Science, Coimbatore, Tamil Nadu. Then she had a lifelong learning course in nutritional support in metabolic syndrome by S-Pen in 2023, and again nutritional support in perioperative period by S-Pen in 2023. Previously, she had covered a course in total prenatal total parenteral nutrition by S-Pen in 2022. She also has a certificate course in early nutrition specialist recognized by Ludwig Maximilians University, Germany. Presently, She has a PhD diploma in diabetes educator course recognized by IDF, and she is now pursuing PhD in food and nutrition from Bhartiya University, Coimbatore. She has many articles and chapters published in Indian and international journals. It's my pleasure to introduce her today as speaker in this session. Thank you.
Thank you, Shonchita Di. I request Principal Sir Panihati Mahavidyalaya, Dr. Devapriya Dev, to say a few words for today's session.
Uh, Good afternoon to all. I
Good afternoon, sir.
especially thank to faculty and staff members of Food and Nutrition Department of GOKHALE Memorial Girls College and the faculty and staff members of Food and Nutrition Department of our college, PANIHATI Mahavidyalaya, and my dear students from both of the institutes. First, I would like to thank dietitian Komal Srivastava for giving her valuable time to enlighten our students on the topic of carbohydrate counting and diabetes mellitus. I personally believe that this type of collaborative program will strengthen our academic activity. Now, the topic of today's lecture is very much pertinent in present day diabetes related health issues. Actually, the particular topic, that is the carbohydrate counting, is a meal planning technique for people with diabetes for managing blood glucose levels by tracking the grams of carbohydrate consumed at meals. With better patient education and awareness, carbohydrate counting has become an important step in diabetes management. People with diabetes can be benefited with this approach via improved glycemic control and quality of life. Very recently, I have interest in this particular topic. I have seen that an article it was published in Nature in which the scientists developed a robust insulin delivery system that includes the automated meal detection and carbohydrate content estimation using machine learning and insulin dosing. So if this type of device can be established, so it is possible, so whatever the diet we are taking, we can count that how much glucose it is accumulated in our body system, and accordingly we can change the diet. So madam will enlighten us in this particular topic. I will not take much time, but again I would like to thank the organizers for organizing such a wonderful webinar. Thanks to all. Thank you all.
Principal Sir, I also welcome you to this today's session. We are thankful that your college has collaborated with us in this webinar.
Thank you, madam.
Thank you.
Thank you so much, sir. Thank you, ma'am. So now I would request our speaker for today, dietitian Komal Srivastava, who is RD, registered dietitian, Apollo Hospital, Salt Lake, to kindly deliver on today's topic without further any ado. So, ma'am, can you please start the session?
Thank you, Pratyasha ma'am. I would like to thank Devapriya sir and Sanchita ma'am for the wonderful introduction. And I would like to thank GOKHALE Memorial Girls College and PANIHATI Mahavidyalaya for giving me this opportunity to have a presentation on something which is very, very important and very much related in today's scenario, that is carbohydrate counting. Now, just share my slides. Kindly let me know once you all see the slides on the screen, whether it is visible or not. Is my screen?
It is visible. Visible.
Okay. In type 1 diabetes mellitus, the group of population that comes to our mind is that of pediatrics. So me being a pediatric dietitian, looking forward usually take care of carbohydrate counting on diet of type 1 diabetes in type 1 diabetes mellitus kids. So when we talk about diabetes mellitus, there is some basic informations which I'll be sharing it right in the starting of the session, so that we get a frame of what exactly we will be talking about in the next couple of slides. So when we say about diabetes mellitus, it is basically a group of metabolic disorder in which there is high blood sugar levels over prolonged period of time. So it is not that one night the person sleeps and next day he or she gets up and says that, oh, it's a diabetes. It's a process that a body undergoes. There are several metabolic changes, be in terms of your carbohydrate metabolism, be in terms of your fat metabolism, be it in terms of your protein metabolism. And over a period of time, if these metabolism or if these problems which the patient is facing is overlooked and not treated in time, definitely it will result in something which is called as diabetes mellitus. And because it involves it's called a metabolic disease because it contributes to other comorbidities along with it. It might be your hypertension, it might be your elevated triglycerides level or rearranged lipid profile, or it might be your pre-diabetes state which the patient or the person has overlooked for a long period of time, and now it's a condition where the person or the patient has developed a full-fledged diabetes mellitus. So where there are various symptoms of diabetes mellitus. In this slide, I have given both for type 1 and type 2. So the most common complaints of a patient with diabetes mellitus is that the patient eats voraciously, the patient drinks lots of water, there is frequent urination, and there is weight loss also. But when you look into the blue color, alphabets or blue color words, it is more of your related to type 1 diabetes mellitus, which includes your lethargy, which includes your smell of acetone, which is basically when your blood sugar levels are very, very high. There's a condition called diabetic ketoacidosis, wherein we see the smell of acetone, we see the hyperventilation or the cosomal breathing in the patients. But again, rest of the things like nausea, vomiting, and abdominal pain is also a very classic symptom of patients or children having type 1 diabetes mellitus. So now looking into the different types of diabetes mellitus. When we talk about types of diabetes mellitus, I have focused only on just to differentiate between the need for carbohydrate counting and why it is important. So basically, first, when we talk about type 1 diabetes mellitus, it is a condition where pancreas, they fail to produce insulin. That means the insulin production is absolutely zero in the body. And when this condition occurs, there is very, very high or elevated blood sugar levels of the patient or the child complains of nausea, vomiting, and this child comes to the emergency with a condition which is termed as diabetic ketoacidosis. That means ketones in the urine and elevated blood sugar levels which are very, very high, to be controlled oral drugs. So the main treatment at that point of time for these type of patients, for these children, is basically your insulin. So insulin actually acts as a lock and key system for delivering or making the glucose entering the cell. We all know that our body utilizes energy by metabolizing glucose, what we eat in forms of carbohydrate. But now if this insulin only active, or the body will be lethargic, and then the patient might have a weight loss also and series of symptoms which is pertaining to the type 1 diabetes mellitus. And the second one is the type 2 diabetes mellitus. So when we talk about type 2 diabetes mellitus, it is a condition where there is insulin resistance. So now what is insulin resistance? It is like the insulin production is there, but the cells are not absorbing or allowing the insulin to work so that the glucose, which is the simplest metabolized form of carbohydrate, enters the cell. And when this happens, over here also this patient feels lethargic. There's no energy. But again, that there is insulin in the body, but again the cells or the receptors of the cells are not working properly. That's why, partially maybe the glucose is getting diabetes mellitus. It is basically no production of insulin in the body. So this insulin resistance can actually be corrected by, lifestyle modification, with diet, with medication. And this person might, at one point of time can have a condition where with only diet only the, sugar levels can be controlled. But in type 1 diabetes mellitus, we can't even think of, only lifestyle modifications or oral drugs that can control the blood sugar levels. By default, it is insulin injections that needs to be given from outside. Sorry. So now when we are talking about insulin, so there are various forms of insulin which is available. So this is something really very theoretical. I will not be going in much details, but again, we need to know what exactly is rapid, regular, and intermediate acting insulin. When we talk about rapid acting insulin, it starts working around 15 minutes of its ingestion, and it lasts for around 2 to 4 hours. So these are the different examples of, rapid acting insulin. When we talk about you start then in 1 to 2 hours and it works for 12 hours. Insulin, which is for it takes 2 to 4 hours and it works for 24 hours. Now quickly looking into what are the basic difference between the different types of insulin and how it is being injected so that the blood sugar of a patient with type 1 diabetes mellitus is maintained. So when we talk about insulin in type 1 diabetes mellitus, basically we use the two terms, that is your basal insulin and the bolus insulin. Now, when we talk about basal insulin, it is actually the background insulin which keeps the blood glucose levels at consistent levels during periods of fasting. Say, for example, a child or the patient goes off to sleep. The most common example of basal insulin, which maximum of us have heard of, because even in type 2 diabetes mellitus, this insulin is quite common and it is being prescribed by the endocrinologist to adult patients also. It's called Lantus. So Lantus insulin is actually your basal insulin, which is usually given at bedtime after dinner, because even when we are sleeping, our body is actually working, our organs are actually working. And to maintain a normal euglycemia level, that is the normal blood glucose level till morning, we need some amount of insulin for night also, or even at the time of fasting. Because if we go off to bed at around 10 or 11 and if we get up at 6 or 7, we are not eating in between. So that becomes our fasting levels. So during that time also, we need to maintain a normal, healthy euglycemia, that is your normal blood sugar levels. So that's why when we always say that once you get up, there has to be breaking of this fast. And then the word comes breakfast. We are breaking the fast. We are taking up breakfast. So that's why it is utmost important, not only for diabetic patients, for all of us, because our whole body was in a fasting state. And once we get up, we should take proper amount of food so that our sugar levels and body activity, be it biochemical or cycles which are happening in the body, is maintained. So when fasting, the body steadily releases glucose into the blood of our cells, which supplies energy, because even when we are sleeping, energy is required to carry on the processes that a body is carrying. So basal insulin is therefore needed to keep blood glucose levels under control and to allow the cells to make the glucose for energy. Basal insulin is usually taken once or twice a day depending on the insulin. So again, it depends on the diabetes educator or the endocrinologist consultant to, divide the dose and prescribe the dose for basal or bolus insulin. But again, for having prescription, there needs to be a record. So, SMBG, we say, that is your self-monitoring blood glucose, is utmost important for patients with diabetes mellitus. So once you go to the doctor and you show the history of your SMBG, that is your self-monitoring blood glucose, so it becomes easier for the educator, diabetes educator, or the consultant to, plan the next line of treatment along with the diet. So basal insulin needs to act over a relatively longer period of time, and therefore basal insulin will either be long-acting insulin or intermediate. So basically, when we talk about Lantus, it is long-acting insulin. So the simple example of, basal insulin is like when you watch a movie, there are songs, there is action, and there are dialogues where you have some background slow music. So this dialogues with background slow music is actually our basal insulin, because it is also required to, you make that dialogue effective. So this dialogue is actually the mechanism that we are having in a fasting state, and that background little bit of music is actually the basal insulin, which is required for that dialogue to work properly. So when coming to bolus insulin, so when we talk about a bolus insulin, it's a dose of insulin that is specifically taken at meal time to keep blood glucose levels under control following a meal. You all, those that if not even on insulin, but you all must have heard that you need to take insulin prior to your meals, maybe before breakfast or before lunch or before dinner. Why is it so? Because when you eat carbs, the blood sugar level rises. So to maintain that blood sugar levels, we need to give a bolus dose. So now you can very well understand that the dose of insulin and the amount of carbohydrates goes hand in hand. So for this reason, diet becomes utmost important for patients who are on insulin. So even in type 2 diabetes mellitus, there are patients who are on oral hypoglycemic drugs. Okay, but again with that also, they are being placed on insulin too. So again, it becomes really very important to balance the drugs, insulin and diet. But when we look into the other aspect, that is type 1 diabetes mellitus, we know that it's a condition where there is no insulin production at all in the body. So when there is no insulin production and the child or the patient keeps on eating, so if insulin is not there, it is not going to work out. So to balance the amount of insulin with the amount of carbohydrate, there comes the role of a dietitian, there comes the role of an educator to educate the patient how to eat, how much to eat, and what to eat. So if you look into this graph, breakfast, lunch, supper, and bedtime, this blue line is your basal dose, that is your long acting, and bolus is like your short acting or intermediate in between, before breakfast, before lunch. Supper we usually don't have in our country. It is basically your dinner, which can be replaced with supper. So now how do we diagnose, which I missed in the initial slides, that the child or the patient is having type 1 diabetes mellitus or type 2 diabetes mellitus? There's a test called C-peptide test. So when we do a C-peptide, there are various tests that needs to be done for a child when he comes and we see that the sugar levels are above 500, 600, 700. And immediately the child is shifted to PICU, wherein the actual treatment with first the insulin ingestion in form of bolus is given to the child, and then rest of the thing follows. Because at that point of time, we don't feed the child. We need to control the blood sugar levels, and this child is actually not in a condition to eat also because of nausea, vomiting, and ketones are always very high. So when we say that the child who has come to an emergency and then enters a PICU, there's a test called C-peptide test, and there's a specific value. So when we see that the C-peptide peptide is very, very low, so what happens? It reflects that the child is having type 1 diabetes mellitus. And when we see it is within the range, it is type 2. But again, it also needs time to rule out whether it is type 1 or type 2. Now, looking into the medical nutrition therapy goals for diabetes mellitus. So, be it your type 2, be it your type 1, the first and the foremost thing for diabetic patients is to maintain the blood glucose levels. So, a child or the patient who has got blood sugar levels of 700 mg per dl entered PICU, we will not, we will not say that, okay, fine, within 48 hours, 24 hours, we need to bring the blood sugar levels down to 90 or 100. That is wrong. But again, gradually, definitely, we need to work out with this child, we work out with this patient so that a normal range for that specific age group of that type of diabetes mellitus is being maintained. Looking into the other things that needs to be maintained is your lipid profile, because we all know that once the person gets this diabetes mellitus, there are various other organs which gets involved. That is your kidneys, that is your heart, which is a major organ for pumping the blood throughout the body, and your liver, your brains, and then definitely the utmost important, which usually in our scenario is being overlooked, is the foot. Diabetic foot care is also utmost important so that there is no ulceration in the feet or foot of the patient. So lipid profile needs to be maintained, because if it is maintained, the risk of cardiovascular diseases are at bay. And blood pressure is absolutely important to be maintained. Now, how do we maintain this, or we approach, or achieve these goals of diabetes mellitus? When we talk about achieving these goals of diabetes mellitus, and we need to slow down the rate of chronic complication, first of all is lifestyle modification. Now, when we talk about lifestyle modification, looking into the different types of diabetes mellitus, we look into the planning or the goals of the diabetes. So when we talk about type 2 diabetes mellitus, wherein we know that there are little amount of insulin production in the body, which can be managed by lifestyle modifications and oral drugs. So that time our lifestyle modification is at most important, then drugs is important, and then diet is important. But looking into the other aspect, that is your type 1 diabetes mellitus. When we talk about type 1 diabetes mellitus, till now we have a clear picture that there is no insulin production. So when there is no insulin production, the first and the foremost thing that needs to be taken care is the treatment by giving proper doses of insulin to the patient. And when we give insulin, as I discussed in the earlier slide, the carbohydrate becomes utmost important. So we need to balance this insulin and carbohydrate for patients with type 1 diabetes mellitus. So now, as I was talking about the targets of the known case of diabetes mellitus, now sticking to this type 1 guidelines as per International Society of Pediatrics and Adolescent Diabetes Mellitus 2018, the HbA1c, which usually is checked in 3 months interval, should be below 7.5%. Fasting blood sugar should be your around 90 to 130, that is your pre-meal, and postprandial it is 90 to 150, that is before going to bed or overnight. So these are the targets that needs to be maintained in a period of time when we start treating the patient. But this target cannot be set in a 24 or 48 hours span. It has to be gradual, because as I mentioned earlier, a patient with 500, 700 mg per dl of sugar levels, you can't target 90 to 130 at one go. It has to be gradual, because the child needs to adjust with the new problems or the new diagnosis what he is having. The child's psychological state we need to understand, because even for checking sugars, the child needs to be pricked. And for treatment, that is your insulin, again the child needs to be pricked. So psychological part also plays a very important role, because all of a sudden if a child gets something like this, it is difficult for child also to adjust. It is difficult for the parents also to accept that my child is having diabetes mellitus. So it's a very, very difficult scenario, and there comes the role of a health worker, paramedics, to make the patient and the family educate, counsel that this is something which is there, which will be there, and needs to be taken care of. So now moving to the main topic, that is carbohydrate counting. So when we talk about carbohydrate counting, it is basically a meal planning approach which is based on certain ideas. First of all, we know that the carbohydrate is the main nutrient, which is a macronutrient which affects the blood glucose levels. The simple example what I always say for this is like when we talk about carbohydrate, it is the amount of rice we are eating, the amount of chapatis we are eating, the amount of cornflakes, suji or semolina we are eating. But is it all or only those cereal products that contains carbohydrate? No. It is other sources in the food pyramid that contains carbohydrate. The first source is definitely cereals. The second source is the pulses. Pulses means dal and products prepared from dal. So you talk about lentil, it contains carbohydrate. You talk about besan, gram flour, it contains carbohydrate. So again, we need to look into the other sources of carbohydrate, what we take in our diet, so that even those food groups are planned accordingly so that the blood sugar levels is normal or within the range and insulin and carbohydrate ratio is maintained. So the other food groups what we keep in mind while planning diet for type 1 diabetes mellitus, looking into carbohydrate counting, is the milk and milk products. The main source of carbohydrate in milk is lactose. So we all know, if we look into our ICMR book, NIN book, so 100 ml of milk usually gives us 67 kilocalories and 4 grams of carbohydrate, which is again lactose. So again, when planning a diet, we need to look into milk and milk products, because if the child doesn't take milk, what about taking curd? What about taking chena? What about taking paneer? So even that also needs to be planned. And last but not the least is the fruits. We all know that fruits contains fructose, which is again a good source of carbohydrate. So while planning a diet for a diabetic patient, be it type 1, be it type 2, carbohydrate and the sources of carbohydrate from where we are getting it is utmost important. And being a dietitian, nutritionist in near future, you all will join our hospital or you will have your own setup. You all should be aware of the other sources while planning a diet for a diabetic patient. So again, the second thing, the total amount of carbohydrate is more important than the source of carbohydrate. This is a very common thing and a very common example which I always give to my students, to others, that the moment the patient gets diagnosed with diabetes mellitus, the first and the foremost thing what the patient leaves or the parents they avoid for kids is rice. They think that because the patient or the family member has turned out to be diabetic, we need to cut down on rice and take chapatis. But when you take a recall, when you find out before planning a diet that how much the patient is eating, you will be surprised to see the amount of chapati the patient is having has not come down. But definitely rice is out from the diet. So it is the amount of carbohydrate what you are eating, source of carbohydrate what you are eating. So if you eat sugars, definitely it will increase on the blood sugar. But if you are not eating sugar, but you are eating 8 chapatis, it will affect the blood sugar levels. So this counseling, this education needs to be given to the patients, to the parents, and to the child also. So total amount of carbohydrate is utmost important. So why this carbohydrate counting has become popular? Because it is very much effective, it is very much flexible, and it can be implemented easily. So it's not again a single day counseling session for parents or the patient. There needs to be follow up once the child or the patient gets discharged. After 7 days, you need to follow up with the dietitian the way you follow up with the endocrinologist or the consultant, and check on the plan that needs to be changed. Because as I mentioned, it's a trial and error thing. So you need to come to the target before, when the patient needs to be brought to that target, we need to move gradually. And this gradually movement itself is a time consuming process. So when the sugar levels are getting controlled, definitely the insulin doses will also need to be curtailed by the consultant. Similarly, the diet also needs to be planned accordingly. So aaj diet chart de diya and you come after a year, that is not going to work out. So this is utmost important in any of the sessions when you are using such elaborate calculation in maintaining the health of a patient, counseling and follow-ups. This is utmost important. So now there are different techniques. First, the most common and the simplest form is a hand guide. Again, when I talk about this hand guide technique, my hand size and the XYZ's hand size will not be same. So it is always good to standardize a diet plan, what is being prescribed to a patient. So that I will take up in the next couple of sessions. So as you can see, a fist means 1 cup, which can vary. A child fist similarly is not similar to that of your his grandfather's fist. So again, portion size becomes a bit difficult when you use this hand guide. But again, it is easier as it is the requirement of that patient when no other options are available. Then we have this cupped hands. Then we use fingertips, and then we use thumbs also. But to be more precise, I usually don't use this hand guide. My counseling session is more on your standardization of diet, what the patient's family is actually taking. So the other tool is by using measuring cups and spoons, which is utmost important. I really emphasize on using measuring tools, which is your measuring cups, bowls, your tablespoon, teaspoon, and again a weighing scale for the kitchen. Nowadays, it is very much easily available in any of your online shopping app and doesn't cost much also. Now, it is not that the child or the patient needs to take only prepared food at home. So suppose the patient wants to have bread. So is it possible for the family member to prepare bread at home? No. So in that context, nutrition levels becomes very much important. And this teaching also usually I provide to my child's parents, so that it becomes easier for them to calculate carbohydrate from the packet food also. So say for example, over here the serving size is 3 pieces, and 3 pieces contributes to around 90 grams. So when we divide this 90 grams, the amount of carbohydrate in 3 pieces, each piece is around 30 grams, which is again, by using unitary method, you can do that. So what you all can do is it's like a practical approach. What you can do, take a bourbon biscuit or Oreo biscuit, a small packet, and over there you get that 100 grams of nutritional informations. See how many biscuits are there in that 10 or 12 rupees bourbon packet or Oreo packet. Then with that, using that unitary method in 100 grams, and check on the amount of packet. So it's not always that the nutritional information is for 100 grams, but maybe the packet size is 50 grams. So use unitary method to find out how much calories, how much carbohydrate is there in one biscuit, or in one portion, or in 30 grams. So it becomes easier. So, until or unless you practice this, or you do it on your own, the concepts will not be clear. So take it as a homework, show it to your ma'am what you did actually. So carbohydrate choices. As I mentioned, the different sources of carbohydrate in a diet, that is not only your, cereals and cereal products. It can be your milk and milk products. It can be your pulses. Am I audible?
Yes, ma'am.
Okay.
Yes, ma'am.
Everything was so silent, so I thought it's like I'm going. Anyways,
No, ma'am. Actually, we have requested the participants to post their queries in the chat box so that you can speak uninterrupted. And then at the end of the session, we'll take up all the queries.
Okay, sure, I'll do that.
Ma'am, I'll just make an announcement 1 minute, since there is an interruption, I'll just make an announcement. I request all the participants to keep a calculator handy with you as ma'am had requested. And one more thing, I have already said in the chat box also that feedback form link will be given in the chat box. I request all the participants to fill up the feedback form properly so that the e-certificates can be generated for you. Thank you.
So now moving back to the session, carbohydrate choices, as I mentioned, it contains your cereals and cereal products. It includes, your pulses, your milk and milk products, and your fruits also. Now, how you are going to make the choices? The most important thing that you need to find out from the patient is the dietary pattern. Now, when you talk about dietary pattern, what is it all about? It is basically the amount and the type of food. So, for example, if you need to plan a diet for a South Indian patient, they will not have rice in the morning. We need to think about idli, dosa, uttapam, and their meals. So, once you get that recall from the parents, what exactly the child is eating, how much the child is eating. Again, if you look into our in Bengali setup, more two patients might have same dietary pattern. Morning they take rice and they go to school, again they come back from school and they take rice. So this can be common, but the amount of rice for two kids will not be same. So if the diet, what menu they are taking, with that the quantity how much they are taking is utmost important, because everybody takes rice, dal, sabzi, fish, chicken, egg, xyz in their lunch or dinner, or maybe veg, but how much they are taking is utmost important. So once you get that data, that how much the child is taking, second, we need to look into at what time the child is leaving the house and what time is the lunch break. Because as I mentioned, the patient with type 1 diabetes mellitus needs to take shots before their meals. So until or unless we know their routine, we won't be able to accommodate the insulin regimen and the diet along with it. So even that becomes utmost important. And extra food what the child was taking, that is your cold drinks, colas, pastries, mithai, chocolates, chips, which is very much common in pediatric population. So all this first we need to take. So when we plan a diet, which I'll be showing you all in next couple of slides. So what we usually do, we put it in terms of exchanges. When I say one exchange, it is basically your 15 grams of carbohydrate. So, okay, now from a slice of bread, we can say it is 15 grams. But what about 15 grams of rice? How much you are going to take? Because your home utensil and my home utensil will be different. So what I usually ask mothers to do is to take the raw weight, cook it separately, and put it in a bowl. Now that bowl becomes a standard bowl for the child. So now each time the rice is prepared at home, mother knows how much quantity of rice of that bowl needs to be served to the child. It's a tedious job definitely for a mother, but I give them 7 days time span once the child gets discharged to standardize the whole menu what they take. And trust me, if this standardization process is not done, the blood sugars are always haywire. I do get parents, I do get patients where this standardization is lagging. They did not standardize, and child is eating voraciously even after getting discharged, and the sugar levels are just not under control. So this is utmost important. Again, mothers, they also feel that it's a tedious job. How I'm going to do it every day? So I always say 7 days is a time span, ma'am. You take 15 grams of atta, wait, prepare a dough of it. You see, आपके घर में से आपके हाथ से या the person who is cooking कितना चपाती आ रहा है. So it's a tedious job only for 7 days, but it will solve problem for coming years. So it is utmost important. So standardization becomes important when we talk about carbohydrate counting for type 1 diabetes mellitus patients. So again, these are the different guidelines. This again, we are moving into the calculation. Till now, we learned about the tools and how to plan and importance of standardization. So now when we talk about calculation, which is our part again, there are guidelines given, which is bit on more on elaborate one. So as per National Academy of Science, Food and Nutrition Board 2013, these are the calculation for calories and proteins for the child with type 1 diabetes mellitus. But again, over here, we need to look into the weight of the child. So for that, the utmost important thing for a dietitian is to assess the patient, do the nutritional assessment for the patient, be it stamp, be it strong, whatever is available. And again, plotting the height and weight of a child in a growth chart. So we know that there are two different growth charts available. That is your WHO, which stands for 0 to 5 years, and above 5 we have this IAP growth chart. So we need to plot it on the growth charts and find out the percentile. 50th percentile is standard, that the child is healthy. Above it is overweight, obese, and below it is underweight and stunted. So we need to look into where exactly the child is belonging to. So again, it's a detailed analysis what we usually do for our patients. So that simple calculation which can be followed by maximum of us is quite easy. For the first year of life, it is 1000 kilocalories. So that means when we talk about calorie calculation for a 10 months old child, how much it will be for 1000 kg for the first year? So that is 1000. But again, moving to more than 1 year of age. So we have specification calories for boys and girls. So age of boys multiplied with 125. So suppose now that I need one volunteer. I'll be putting up one question. A boy is 6 years old, and we need to calculate the calorie for this 6-year-old boy. And we need to find out how much calorie needs to be given. So 125 multiplied by 6, how much?
750.
750. So this 750 we need to add with 1000 kilocalories. So with that 1000 calories, 750. So that means a 6-year-old child's calorie requirement will be 1750. Okay. So this is how you can calculate on the calorie requirement for a child. Now this calorie estimation or calculation is utmost important. Why? Because based on this calorie, we will be distributing the carbohydrate, proteins and fats for the day. So now, for example, we got to know that 1750, please someone note it down, is the calorie requirement for a 6-year-old child. So now moving into the distribution of macronutrients, that is carbohydrate, proteins and fat for a patient with type 1 diabetes mellitus, because we need to calculate the carbohydrate. So carbohydrate should provide around 50 to 55% of the total calories, wherein 2/3 should come from the complex carbohydrate. Now again, I need a volunteer. 1750. That from there, how much should be the calorie if we calculate with 55% of the carbohydrate? Anyone?
962.5 kilocalories.
So it was 1750 into 55 divided by 100. 962 kilocalories. Absolutely right. So 1750 ka 55% is your 962 kilocalories. So when we know that 1 gram of carbohydrate gives us 4 kilocalorie. So 962.5 divided by 4 will give us the grams of carbohydrate. That is your 240 grams, if I'm not wrong. Yes or no?
Yes, ma'am.
Yes, ma'am.
Everybody
Yes,
get
madam.
my point? Okay. So it is 240 grams of carbohydrate. Now, as I mentioned in the earlier slide, that one exchange of carbohydrate is equal to 15 grams. Okay, so now if we divide this 240 by 15, so that means 16 exchanges of carbohydrate needs to be given for a patient whose calorie demand is 1750. Am I clear, students? Do you all need to repeat this?
No, madam.
Yes, ma'am.
Okay, very good.
Yes,
So now
ma'am.
when we talk about this 16 exchanges, now this 16 exchanges is actually
Ma'am, I think some students they want a repetition. If I'm not mistaken, does anybody want a repetition?
Yes, ma'am, I do.
Okay, ma'am, can you please repeat?
okay. Okay. So till now we got to know that a 6-year-old child's calorie requirement is around 1750. Now from that 1750, we need to calculate the carbohydrate, proteins and fat. Now when we are calculating first on the first macronutrient, that is carbohydrate, we are taking 50 guidelines. As per the guidelines, we are taking 55% of the calories. Now that calories what has come up is 1750. So 55% of that 1750 is equal to how much calories, student? The one who could not understand, please do the calculation, because until or unless you do the calculation, things will not be clear to you. That's why I asked Pratisha ma'am to ask the students to keep a calculator. So 1750 into 55 divided by 100. How much is the calories you all are getting?
962.25.
I hope everybody is clear till now. Till here. Everybody.
It's
Yes, ma'am.
962.5.
962
5.
Okay. So that is clear for you all. Okay. So now we have got the calories from carbohydrate. But now we need to look into how much grams of carbohydrate needs to be given. We all know that 1 gram of carbohydrate gives how much kilocalories, students?
4 kilocalorie.
Okay. So this calories what you got is your 962 divided by 4. How much you all are getting? Tell me.
240.5.
कितना? 240.
Yes, ma'am.
सबको ये मिला है ना 240?
Yes, ma'am. 240.5 they have got.
हाँ, ठीक है. So now, as I mentioned in the earlier slide, one exchange is equal to 15 grams of carbohydrate. So this 240 divided by 15 will give us the exchange. So now divide this 240 by 15.
16.
Okay. So now clear? Everybody? I hope that you all don't need to. Okay. So now you got 16 exchanges. So now this 16 exchange is actually the carbohydrate, which includes your cereals, which includes your pulses, which includes your milk, which includes your fruits also. So now we know how much needs to be given in meals, major meals, in snacks for the patient. Moving to the proteins, it is from here only we need to calculate as per the age and the weight of the child once we get from the patient, from the file. And fat should be around less than 35% of the total calories. So now looking into the impact of food on the blood sugar levels. As I mentioned, after taking fruit within half an hour, there is a peak in the blood sugar level. When you take starch, it takes 2 hours for the sugars to rise. When the starch is or the diet is in high fiber or high amount of fiber is given, the rise in the blood sugar will be there, but it will take around 2.5 hours. This is the reason why, diabetic patients, we say take more complex carbohydrate because it has got more of fibers. Wherein proteins and fats, they don't have much impact on the blood sugar levels. So we need to look into the starches, fiber, and fruits in the diet. Now, looking into the fiber as per the current recommendations, this is something really very subjective. I'll just go through the AAP, that is American Association of Pediatrics guideline, which is again in 2012. It is age plus 5. So if the child is 6 years age, as we have calculated for 6 years old child, plus 5. So that means how much is the fiber requirement? 6 plus 5 is 11 grams. So that means the fiber requirement for this child will be 11 grams. So now looking into the carbohydrate distribution across the meals. So depending on the insulin, the type of insulin, and most importantly, the activity of the child, the carbohydrate needs to be distributed. If the child leaves home at 6 o'clock, we can't expect the child to get up at 5:30 and take full meal. No. So in that context, we need to find out what exactly the child takes and goes to school. Then once we get that, we calculate our own calculation for carbohydrate counting. We spread that and then we inform, okay, fine, the child will be taking 20 grams of carbohydrate before going to school. So the insulin will be adjusted accordingly. So it goes hand in hand, insulin, carbs together. So now moving to the other calculation, which is your insulin to carbohydrate ratio, which is utmost important. So we follow two rules out here. That is rule of 450 and the other one is rule of 500. So this insulin to carbohydrate ratio varies from patient to patient depending on the TDD. Now what is this TDD? TDD stands for total daily dose. T is for total, D is for daily, and D is for dose. So we need to find out first what type of insulin the patient is on. So if it's a regular insulin, so now the example of regular insulin is your NPH, Humulin R. So what we need to do? We need to look into the total daily dose of this regular insulin and we need to divide it with 450. And when it is rapid acting insulin, like your Nova Rapid, we use rule of 500. So say for example, if the patient total daily dose is your 45 units of insulin. Again, mind that diabetes educator and a endocrinologist, they are the right person and the authorized ethical person to, prescribe insulin. Dietitians can definitely modify that, but again, it is their chapter, their topic. They need to adjust or they need to, titrate this or prescribe this insulin for the patients. So once we get to know the total daily dose. So if we find out that the patient is on regular acting, so what are we going to do? For 45 units a day, 450 divided by 45 will give us the amount of carbohydrate. That means for this patient who is on regular acting insulin, the carbohydrate to insulin ratio is 10 grams. Wherein if the patient is on rapid acting, carbohydrate to insulin ratio is your 11 grams. But again, to come to this point of insulin carbohydrate ratio factor, we need to have a strong background of SMBG. That means self-monitoring blood glucose is utmost important. How much the child or the patient is eating, along with the insulin dose which is being provided. So if we get a record, that's why when the patient gets discharged from ward or to the back home, so the most important thing is we always ask them to monitor the blood glucose levels and record it, because how much insulin was given prior to breakfast and then what was the sugar levels before the lunch, because it will have an impact on the blood glucose levels after 2.5 hours. So this also becomes easier for us to titrate the carbohydrate and the insulin in the next visit. So we keep on doing this until we get a point where we know that the blood glucose are in control, because we are following that target guidelines as I showed in the last couple of slides. Now we look into the insulin sensitivity factor. So say for example, a child goes to a birthday party and he takes a big piece of cake. So what are we going to do? Will we ask the child not to go to birthday party? No, I never do that. I ask the child, I always counsel parents, the child will have a normal life. But again, we need to learn first to control and certain things that cannot be overcome or cannot be overlooked. You need to socialize, you need to go out, you need to eat good food also. But again, in moderations, because taking high fat food is not only unhealthy for that patient with diabetes mellitus, it is not healthy for us also. Taking excessive salt, packet food is not healthy for them, not for us also. So a diabetic diet basically is your normal balanced diet for all of us. Because if we are taking excessive sugars, we are taking excessive amount of salt, it is going to affect us also. So it is not because the child or the patient has developed diabetes mellitus and he needs to or she needs to curtail the whole routine of hers or him. But we need to learn to control. But again, there are cheat days. We need to socialize, we need to go out, we need to eat good food. So now if this child has taken a big piece of cake, so what are we going to do? We are going to use this insulin sensitivity factor or the correction dose or the correction factor. So what we are going to do, we need to find out the total daily dose, and with the standard, that is your 1700, we will divide this TDD. So once we divide this TDD varies from person to person. A child might be having a TD total daily dose of 30 units. A child might be having a total daily dose of 11 units. So this total daily dose varies from child to child depending upon their target levels and the blood glucose level. So when this 1700 divided by TDD, we get the amount of glucose that 1 unit of insulin will metabolize. So this is how this excess blood glucose levels, if happens after taking, unplanned meals or excessive sugars or outside food, we usually follow this calculation to control the blood sugar levels. So now, what is our take-home message? First, we need to recommend calorie, which is a mixture of carbohydrate, proteins, and fats. Carbohydrate has to be from a complex sources also. Food needs to be divided into major meals. So, like it is common for all of us. We need to take breakfast, we need to take lunch, we need to take dinner. But again, snacks is also utmost important so that, the sugar levels are maintained and your metabolic rate, BMR, is also maintained. Carbohydrate exchange should be taught to the family. This is very, 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 very important. And as I mentioned, it cannot be done in one single day. We need to maintain the growth and development of the child. Utmost important, because the child has lost weight. We need to bring the child to that standard weight of that specific age. For in pediatrics, we say weight for height is utmost important. Height for age is also utmost important, keeping in mind the other factors like the height and weight of the parents also. But again, when we look into the growth chart, that needs to be maintained for the child. And it needs to, we need to evaluate that for 3 to 6 months interval. All family members should eat the same meal prepared for the child. So as I mentioned, there's nothing called diabetic diet. Definitely carbohydrate counting is a technique in maintaining a balanced diet, but it cannot be a child taking altogether new food because he has developed diabetes mellitus. And a snack is utmost important because we are dealing with the pediatric population. Type 1 diabetes mellitus is more seen in pediatrics. So before any school activity, sport activity, physical exercise, a snack, a healthy snack. A child having a cake is also a snack. A child having sprouts with cottage cheese is also a snack. So we need to choose it wisely what we are going to give our child. I think that is the end of the slide. Thank you.
Okay. Uh, Thank you so much, ma'am, for your wonderful session. I think we'll take up the queries now. So, one of the question by one of the participants, that is Mishtu, should people likely to have diabetes eat regularly throughout the day? And feedback.
Pratyusha ma'am, just a minute. My laptop battery has
Yes,
drained.
ma'am. A feedback form has been given in the chat box. I request all the participants to please fill it up so that the e-certificates can be generated. Of course, it will take some time for the e-certificates to be generated.
Okay, ma'am.
You will get it in your mail.
Tell me.
Ma'am, kindly repeat, please.
Sorry. Uh, Anybody said something?
We can have questions now, ma'am.
Yes. Ma'am, the first question was, should people likely to have diabetes eat regularly throughout the day?
Sorry?
People likely to have diabetes, should they eat regularly throughout the day? Am I audible?
Yes, ma'am.
Tracking actually.
Ma'am, can you stop presenting? Yes.
Yes, ma'am. Wait a minute. Okay, ma'am.
Yes, ma'am. I was saying the first question, should people likely to have diabetes eat regularly throughout the day?
See, we always suggest to have major meals. We don't ask them to skip meals. That is your breakfast, lunch, and dinner. See, when we look into our aspect, we being non-diabetic, so we also take breakfast, lunch, and dinner. So there is no difference in the major meals pattern. But when we plan a healthy diet plan for anybody, we always say to have small snacks also. A snack can be your intermediate fruit also, or in evening maybe a cup of milk with 2 biscuits or any other cereal. So snacks also is important, and major meals is important. So there's nothing, change or drastic change in the diet of a patient with diabetes mellitus. It is like what we eat, it is the same thing. But yes, again, quantity is at most important, and the type of meals that are planned for these kids are also important.
Okay, I think Mishtu has got her question answered. She had another question, in fact, that how often should we take dietary fiber given its importance in our daily life?
The dietary fiber is important because it has got hell lot of importance in the body. So when we talk about taking carbohydrates in the diet, so when we plan a meal, it contains vegetables also, and we know vegetables and fruits are a good sources of carbohydrate. So in my slide where I mentioned about the fiber recommendations, it was mentioned that in how much grams of vegetable will give you equivalent amount of recommended dose. So 450 grams, it is 250 grams of vegetables will give the equivalent requirement of the fiber for the day. That is the recommendations.
Yeah, actually, you have said in one of your slides, but I think somebody has missed it. So they have again asked for the full form of TDD.
Total daily dose.
Yes, ma'am. And I had this question actually, that you said that, ma'am, after 5 years, that is children above 5 years, we should use IAP growth charts for them to assess their nutritional status. Ma'am, can we also use CDC growth charts? Because our students, they only told me that they did their internship in CINI, and there they were taught the CDC growth charts for children above 5 years.
See, it depends from institution to institution. we usually follow IAP stands for Indian Association of Pediatrics.
Yes,
So
ma'am.
those guidelines were prepared keeping in mind and doing the study on a pediatric Indian population. So I think it is always good to use things which pertains to our country, our the studies which are done on our population. CDC is absolutely fine if it is comfortable by the organization, but there's no harm in it. But it depends from organization to organization. We usually follow this IAP and WHO.
Okay, ma'am. Thank you. And ma'am, I also wanted to know one more thing that you were, I think you mentioned, if I'm not mistaken, because I was also into too many things, I may have made a mistake, but I think you mentioned that rice for type 1 diabetes mellitus. So do we totally omit it for type 1? No.
Never. It is the quantity that needs to be checked. So there comes the role of importance of standardizing a diet. So once we plan it and we explain the mother, we ask the mother to usually 7 days span. In that she needs to standardize how much it is coming in the final weight. So we plan it in a raw weight amount. She needs to cook and find out how much it is in a cooked amount.
Ma'am,
And ma'am, one more thing I want to know, like today mainly you have talked about type 1 diabetes, carbohydrate counting, but ma'am, even patients who are type 2 diabetic and they are on insulin, I think the same concept will apply for them, right? Of carbohydrate counting.
Yes, it will definitely apply, but again, it is, they have insulin, we need to keep that in our mind. So even if they take 30 grams extra rice, their drug will definitely curtail that. But when we look into type 1 diabetes mellitus, we need to inject a little extra dose of insulin.
Yes, ma'am. But then we will do the carbohydrate counting for type 2
We
also.
can have a normal plan also using the exchanges. We can have carbohydrate counting also. It depends. But when we talk about exchanges in general, what we plan for XYZ cannot run for type 1 diabetes mellitus. For type 1 diabetes mellitus, it is only carbohydrate counting. Again, if it is insulin pump, it keeps on changing. So it depends on the techniques, how the insulin is being injected and the diet, what needs to be planned.
Yes, ma'am. Yes, ma'am.
ma'am, I have a question. Can I ask it?
Yes, go ahead.
Ma'am, can we include artificial sweeteners in a diabetic patient's daily meal regularly?
Okay, artificial sweeteners usually we don't prescribe pertaining to the today's topic. It's type 1 diabetes mellitus and carbohydrate counting, which is more in pediatric population for children until 18, for pregnant and for lactating mother. There's no guidelines we say that they can take artificial sweeteners. It's only after 18 or pregnancy or lactation phase. It is not prescribed. It is not advisable. Again, if you want to give or the patient wants to have, there's natural sweeteners available, artificial sweeteners, which is bit of on a expensive. So that can be added, but definitely not on regular basis.
Okay, ma'am. Thank you, ma'am.
Ma'am, there is another
Okay,
question.
Pratyusha, another question come from student side, that is
Yes,
they
I'm just
want to know if there is kidney disease or kidney stone with diabetes mellitus, then how diet chart will be planned. This is from student side.
Okay, so first of all, you are talking about type 1 or type 2 diabetes mellitus?
That's not mentioned.
Okay, so see, carbohydrate counting with kidney disease has no impact. Again, when we talk about kidney disease, we need to maintain the blood sugar
He has
level.
mentioned type 1. Type 1.
So when we need to maintain the blood sugar levels with type 1, carbohydrate counting will definitely go. When we talk about kidney disease, we type 1 and type 2, we need to find out what type of stone it is. So depending on that, the nutrient or that needs to be curtailed will definitely be your calcium or phosphorus, which one needs to be curtailed. So it depends on the type of stone what the patient is having. Not with the carbohydrate. We need to look into the kidney stone diet chart.
Okay, ma'am. There is one more question. If someone is in serious condition of diabetes and also affected by stones in liver and got infection, then what they will do?
Definitely, this patient will be in hospital setup. So, as per the treatment plan, whether it's an insulin bolus or shots, we will be planning the diet accordingly.
Yes, ma'am. And ma'am, one more thing. Like I think personally, also as far as my information goes, artificial sweetener should not be a replacement for sugar for diabetic people, whether it's type 1 or type 2, right?
Usually, I don't suggest, because I deal with the pediatric population. I say absolutely no to my patients, to
Yes.
pregnant lady also, and to lactating mothers also. It is no from my end.
Yes, ma'am.
Is
Ma'am,
it
one
true that, is it true, this is my question, is it true that artificial sweeteners may aggravate kidney stone?
So we have to look into the papers suggesting that whether artificial sweeteners can precipitate kidney stone.
Yeah. Okay, okay.
actually the main thing is artificial sweeteners. They will trick our brain to further have more sweet foods. So that's the main reason I think we should not include artificial sweeteners. Plus, many of them, when we use them in cooking or baking, the chemical composition changes. They may not be very, they may be harmful for our health. So, and plus amount that we take in, that amount we do not know. Most of the patients, they do not know what is the permissible amount beyond which it will be harmful. For these reasons, I think artificial sweeteners need to be omitted from our diet. If I'm not wrong, ma'am.
See, it depends from person to person. If the person is very much keen that I want to take sugar, you can't stop. If the child or the patient doesn't want to maintain a diet, you can't force them to maintain. So there comes the difference.
Ma'am, can fruits not be used as a replacement then in small portions?
Yes, definitely. When we plan a diet for any of the patient, be it type 1, type 2, even for weight reduction, our fruits are definitely included in a diet. It depends on how much calories you are giving, and accordingly the carbohydrate or the calories needs to be distributed. So we keep major calories in your breakfast, lunch, and dinner, then small snacks. So as I mentioned, a handful of nuts is also a snack, and a fruit is also a snack.
Yes.
So you have to choose it and plan it wisely.
Ma'am, one more question. Once my friend told that if water is discarded after boiling the vegetable, the glucose intake can be decreased. Is it logical?
I have not heard about vegetables, but again, there's something called resistant starch, which works on it. It's a separate topic. So I think you can arrange a session with someone with, talking more on this resistant starch topic. So it becomes easier for them also to understand what exactly is happening.
Okay. Do we have any more questions, Swati?
I think all important question we have asked
So,
already.
yes, one more question has come. Can a diabetic patient consume green chireta, mane kal meg decoction?
What is it?
Chirota jol. বাংলাতে যেটা বোঝায়।
Yes.
Is it useful for diabetic patients?
See, there are studies for all these things. You need to look into the research papers and find out that with ingestion of how much grams was, you had a fruitful result. But when you talk about type 1 diabetes mellitus, I'm sorry, I don't think so it is going to work out, because we have to keep that thing in our mind. There is no insulin production.
Yes, ma'am. And ma'am, one more question. A family with genetic flow of diabetes, can that be, means it's already there in the family, so if that can be prevented with dietary modification?
You can delay it by having a healthy lifestyle, but you are carrying that gene. So one trigger is enough to have this complication, because genetics play a very important role in any of the disease condition. So if my father was diabetic, so it is there in my gene. So I need to maintain my lifestyle, but a trigger will be just enough. A small trigger, if it wants to happen, it will happen, because it is there in my gene. So I need to maintain it throughout.
Yes,
So it's
ma'am,
like
very
that.
true. And ma'am, one more question. How can we manage a diet plan of adolescents age 18 years with blood sugar 230, moderate lifestyle, weight 45, height 148?
You come to my clinic, I'll plan it for you.
She wants a diet plan basically. So, ma'am, I think whatever questions I've got, I have taken up those. If anybody has any other questions which we have missed out, you can please ask. Ma'am is still there. Is type 1 diabetes managed? One question has come. Is type 1 diabetes?
If you learn the technique, you can manage. You
Okay,
can
ma'am. Thank
manage
you.
and maintain a very healthy life with it.
Okay, ma'am. Thank you, ma'am.
Anybody has any questions?
Ma'am, I had one question.
Yes,
Please go
yes,
ahead.
tell me.
Ma'am, when a patient is detected with diabetes, should we put him or her instantly on a strict diet, or should we give him or her some time to adjust with the diet? I mean, for psychological reason, I am asking this.
So it depends on what type of counseling you are doing. If the child wants to have a glass of milk with Bonvita and the child is on insulin, so you need counseling there. So maybe instead of giving 2 spoonful of Bonvita, it can be only half TSP of Bonvita. Usually what I suggest mothers is like you boil milk with kesar and elaichi, cardamom. So it will give that flavor to the milk. So basically the taste, many of the kids, they don't like the taste of milk because it has got a very, smell what they don't like. So if you boil it with some other component or another food item, so it will definitely change the flavor and the taste too. But
Ma'am,
again, if from a recall, if you find out that the child take 1 bar of chocolate every day, it is actually no. Because you don't want moderations in eating chocolate, because moderations will always keep your insulin dose on a higher side. So you need to
Ma'am.
again choose it wisely what exactly you are counseling to the child. Yes, tell me,
okay, ma'am.
Shreya.
Thank you.
Can type 1 diabetes affects our sleep?
Yes, to some extent, yes. Why not?
Okay,
How
ma'am.
much amount of fruit is advised? There is a question by Sudeshna Sinha. How
It
much
depends
amount?
on the amount of carbohydrate that has come up with the calculation. Because we talk about exchanges, how much exchange needs to be given, and then there is some allowance for fruit also. So maximum 100 to 200 is enough in a day. Again, depending on the calories prescribed. So if a calorie is 1000 calorie, you will not give 200 grams of fruits. You will stick to 80 to 100 grams, which is a standard for all of us.
I think, ma'am, this diabetes also children in type 1.
Sorry.
So how is the type 1? The question is type 1 diabetes carbohydrate counting for children. How is it different for type 2 diabetes carbohydrate counting for adults?
No, carbohydrate counting will be same for even the adult who gets diagnosed with
Ma'am, could
type
you
1.
hear me?
Yes, yes,
Am
yes.
I audible?
Am I audible?
Yes.
Okay.
Yes,
So
yes.
when we talk about carbohydrate counting, be it a child, be it or adult, the calculation remains the same because the disease is type 1 diabetes mellitus.
Yes. Anybody has any other questions? You can please directly ask the speaker. She's still there. Uh,
No, still there is
Swati,
no another question. The session is very
any
informative
questions?
for students, I think.
Swati, I think.
Students will get so many concept, clear concept.
Oh, is there? Yes. Okay, ma'am, there is one question. Is fenugreek seed water, ma'am?
Yes.
Ma'am, the question is fenugreek seed helpful in lowering the blood glucose levels? If yes, how?
What? Which seed?
And fenugreek seed, methi dana.
For type 2, it really works. But as I mentioned, we need to look into the background of the disease condition. Where there is no insulin production, what do we want the pancreas to do?
Yes.
What we want the cells to do. So everything is from outside. Ma'am, you are not audible. You are not audible.
Sorry. Ma'am, what are the main dietary objectives for the ones with type 1 diabetes whose weight problem is a concern?
Weight gain is a concern.
Yes, ma'am. Dietary objectives for the ones with type 1 diabetes whose weight problem is a concern. She has written problem, so I think it must be gain. It's by Jyoti.
Weight gain. Again, see, when I mentioned in my slides, a type 1 diabetic child comes up with, history of weight loss. So from there only our challenge starts, that we need to bring the child to the standard height and weight for that specific age. So when we are doing that, we are prescribing a diet so that the child eats, the carbohydrate get metabolized, proteins are adequate, fat is also enough so that your fat soluble vitamins are being utilized, so that the child gains weight in another couple of days or months. Because we always say to check the weight of a child once we start giving insulin, because when insulin is not prepared in the body, there is a weight loss. When you start giving insulin daily, there is increase in the weight by maybe 10 grams, 100 grams, 200 grams. So that we need to monitor. So that is monitoring that, gaining of 200 grams is enough for us to, target that with this span of time, the child will gain weight and we will achieve the target weight for the child.
Yes, ma'am. There is one more. I think this is the last question. There's one more question. What does the 15-gram carbohydrate exchange mean? This is a question by Dona. 15-gram carbohydrate exchange का मतलब क्या है?
15 grams. So
Yes,
that was the first thing which I spoke about in the session. So one exchange is equal to 15 grams of carbohydrate. So this 15 grams is a standard, but this exchange varies from person to person. So depending on the total daily dose, we find out how much will your body need to metabolize, or 1 unit of insulin will use XYZ grams of carbohydrate. So we need a calculation for that, because the standard guidelines is one exchange is equal to 15 grams.
Okay.
Any more questions? I can't hear you, ma'am.
Yes, ma'am. Actually,
any more questions?
Thank you so much, ma'am. You have patiently answered so many questions, and thanks to all the participants also for being so curious. So I think we are moving towards the end of our session today. I just request everybody, if you could just put your video on for 1 minute. I would just take a screenshot of this webinar. That will be helpful. If everybody could just put your video on for a minute, please. It was a very delightful session. I think very good comments are coming. It was a useful, curious session. The lecture was very nice.
Thank you. Thank you.
Yes, ma'am. And it was thought provoking. So many comments have come up. And I hope that everybody has filled up the feedback form. I hope all of you have done that, because e-certificate generation will be based on that, and you have to give your email ID correctly so that in your email you will receive the certificate. It was a wonderful lecture and fresh perspectives, three views on all of you. Are you there?
I can't hear you, ma'am. Your voice is cracking.
Yes, ma'am. Maybe network problem. I'm just requesting video on. Yes. For a few minutes, please put your video on, all of you. Okay. Okay. Thank you. So, ma'am, we'll end the today's session. I would like to share the vote of thanks. First of all, I deem it a great honor and privilege. Ma'am, am I audible? Am I
Yes, ma'am.
audible?
Yes, ma'am. You are audible.
Yes.
Can hear
Yes. So I deem it a great honor and privilege to propose the vote of thanks for today's session. I extend my thanks to our esteemed speaker, first of all, dietitian Komal Srivastava, for accepting our invitation and sparing time from her busy schedule to grace the occasion and enlighten us with her knowledge, because we know very well she was very busy, and that's why we could not arrange for a seminar and we made it a webinar instead. But we did get a good participation. Many participants couldn't join because GMeet has a capacity of 100, but we have Shomita ma'am, who has done live streaming, YouTube live streaming, so that everybody else can also watch the program live or later also. Komal ma'am, we are grateful to you. I'm also grateful to our principal, Madam Dr. Atashi Karfa, for her continued encouragement, support, vision, and stewardship. Our principal, ma'am, could not be present today as the chief patron of the webinar because she is unwell currently. That is the reason we requested our IQAC coordinator, Dr. Shonchita Sen, for her presence, and I'm thankful to her for her guidance support also. I would also like to thank Principal Sir of Panihati Mahavidyalaya for his presence and his important speech that he gave. He spoke about diabetes. Thanks to the faculties of Food and Nutrition Department of Panihati Mahavidyalaya, Swati Rai Chaudhary and Shomita Das, for their wonderful coordination and support, without which today's program could not have been arranged. And thank you for the YouTube streaming of the event carried out by Shomita. My hearty thanks to all the participants for their presence, which made today's event successful. I would also take the opportunity to thank my students of semester 5, especially Anushka Jana, for preparing the flyer as a volunteer, and even Koel Mandal, who also volunteered in helping in this webinar. Once again, I would like to thank everyone present here for their contribution in making today's event a great success. So, thank you, everybody. Thank you so much.
Thank you.
Thank you.
Thank you. Have a wonderful
Thank you,
day.
Swati.
All the best.
Thank you, ma'am.
Welcome.
Thank you,
All the
ma'am.
best to everyone.
Thank you, ma'am.
Bye bye. Bye bye.
Thank you, ma'am.